risk the hypoglycemic episode, and because that was more harmful at that time.
You know, and there are agents out there that with very low risk of hypoglycemia attached. That metformin, for example, does not induce hypoglycemia. So, you know, that's a good one. We've got new agents now that have lesser risk of hypoglycemia, but their costs can be exorbitant, so you have to be careful with those. What really ticks me off is when I see a patient come in, and one of these elderly patients from a nursing home or from somewhere else on a sulfonylurea that's known to have high hypoglycemia rates. And they come in, and they're in the hospital, and then leave on the same damn medicine. Right? And what happens? You know, they come back in. And that has got to stop.
So I think you're absolutely right. I think the huge challenge is that when you have these measurement tools, and these measurements ourselves that we risk adjust, but then the point being is that it's really about the individual patient and how you use it, and it's not about that measurement. How do we kind of separate that mix, drive around the risk adjustment, which is really a kind of after the fact to the real life situation, and helping, you know, clinicians understand that the comorbidities are clearly important under those circumstances, and identifying, you know, that maybe this patient is not where you need to focus your interest are, because you've driven the measurement so much that I think we run into this problem is that, you know, people are thinking in terms of those numbers and less about, you know, this risk adjustment that should be in the head of the clinician when they identify these patients. And so somehow, some way, we've got to be able to flag that when you have something electronic, and we need to figure that out in a really effective way. I think, you know, when I think about the patients who have come in with severe hypoglycemia, it's kind of like a duh, but you know, yeah. But still there's this pressure. You know, you
right.
think, well, how did this happen? And you see that this drive toward, you know, meeting quote unquote the goal.
I think this would be driven home a lot more if we collated the data the patients collect and had them similar to you do in an inpatient setting, where all those numbers go into a common repository, and we can see what the true hypoglycemia rate is, realizing that in the outpatient setting, we're missing tons of hypoglycemia that happens that the patient does not record, that we don't even capture the ones that they do record. You know? And there's a lot of work being done there around continuous glucose monitoring and so on. There's lots of bells and whistles, most of which aren't really ready for prime time outside of the type 1 patient with sub-Q insulin pump. But I think there's great promise as we get more and more digital to monitor better and be smarter. We'll just have to look for those opportunities as they arise. But I think this whole thing about taking care of the patient without context is a real problem, I think, and the whole contextual coordinated care is where we need to try to get to, and it's just not easy. It's easy to find an expert on hypertension. It's easy to find an expert on diabetes. It's easy to find an expert on dementia. It's hard to find a doctor or a nurse who can take the best of what those experts have to offer and blend it together and offer the right mix for the individual patient. That's an art form. And if you don't call the question, then people, the more and more we call for, you know, standard measures and standard targets, the more we are at risk for harming our patients by trying to hit those targets.
So first, Bridget Levitch, and then I have a large contextual question about our higher rates of heart attacks and strokes in the Sacramento area and how this might feed into it. Bridget.
So probably stating the obvious, but I just wanted to say that anytime you have a patient who has a chronic illness like diabetes, type 1 or type 2, and they have an adverse effect like this, I just think it's really important that part of the process of getting that patient through and over that bump in the road is to educate and take that as a learning opportunity for the patient as well, because that patient is going to go home or is going to go home with home care. And it's really important that they recognize what that symptom was and what the cause was and what the treatment was, so that they're just a piece of the puzzle as well.
Yeah, it's a good point. You talk about that, engaging the patient in their own care, or not the patient, in cases of, you know, problems with cognitive problems or whatever, then they're helpers.
Did you make an attempt at adding that component to your best practices work at UCSD?
We did a lot of work around educating and providing cues about what those hypoglycemic risk factors are and making sure that we adjusted the total daily dose based on those risk factors. So we would give, you know, the slides in there show that there's text cues, not as well as I would like, because it's difficult to build this algorithmic clinical precision support in there, but there's text cues that say, if they've got these risk factors or prior hypoglycemia, go for this lower total daily dose. 0.3 units per kilogram per day instead of 0.4, 0.5, or 0.6. Okay, so that's the main way we built the guidance in there around trying to get the prescribing.
Dr. Manning, I think that SHM, the Society of Hospital Medicine, has a portal for reporting hypoglycemic rates. Is that right?
Yeah, that's the one that we ported there from UCSD. We built those measures at UCSD. We built the architecture at SHM so that anybody can upload their data there. And it's a fairly simple process, but you know, and it's low cost. It's just covering the cost that it takes to maintain that data set and do the benchmarking. It's like, I think, I believe it's $1,500 or $2,000 a year for all your glucose data. And that's hundreds of thousands of data points usually. And it gives you the ability to do on-demand reviews of your performance, looking at trends and summary reports on any group of units, as well as the benchmarking studies I showed you. I showed you exactly where you're at with the variety of benchmarking reports. Okay, thank you very much.
Oh, no, there are many more questions.
And they're all from you.
Well, they might be. I mean, between us, we can certainly come up with it. But when you have a patient that has multiple hypoglycemic events in the hospital, do you have a special program for them before they're discharged? Because those would be predictably people who are going to be readmitted.
Well, you certainly should have. I mean, what we built at UC San Diego, we don't yet have the full infrastructure at UC Davis, but we found that we could only get so far with protocols and clinical decision support and education. And after that, you needed to have somebody whose job it is to monitor glucose problems and work on protocols and do the education and educate the educators day after day after day. Most of our hospitals don't have a single diabetes educator in them because we don't get reimbursed for it, right? So at UC San Diego, what we eventually built after a number of bad outcomes that our patients suffered was a lead endocrinologist who was dedicated to inpatient diabetes with 3 advanced practice nurses who had special knowledge about diabetes, and they were amazing. They were totally amazing and totally transformed and took us off this plateau that we had reached and took it to the next level because they could do this measurement stuff we talked about. They could do real-time education. They could see, you know, through informatics we often help them build, they could see who is not getting, having their hyperglycemia addressed or who is on a downward slope at risk for hypoglycemia, and they would intervene before the patient ever got hypoglycemic, or if they got hypoglycemic once, they would go and work with the team and make sure that it didn't happen twice. They would do competency training for the nurses. It was amazing the difference and how much more they were able to push out of the system. So all those results I showed you in that one paper that we just published, those were all results after we hit that plateau and brought in those that special team. So having a dedicated group to really work on that on a day-to-day basis really helps in the inpatient setting.
Do they follow the patients outside? I mean,
They don't follow them, but they do try to build bridges into the outpatient diabetes clinic or whatever, you know, whatever scenario you've got in your own health system. You know, again, that's all dependent on what system you've got and where you have to transition them to. And in many cases, that's also under-resourced. But it really can have an intense downstream effect because they were getting a lot of, the patients were getting, problem patients were getting a lot of education that would keep them out of the hospital. They were getting a more rational approach to their insulin and that they could understand. And as, even though I'm a supposed national expert, when I was on the wards, I did not have time to go through every point of this with the patient to keep them out of the hospital the next time. And we would consult them, and they would do everything that I could have done and more, because they're looking at all the details of where you pick up your syringe. Is your meter right for you? Will you be able to get the strips for that meter? All these details that no doctor, you can't expect them to really follow up on all those things. You need a dedicated team to really work on that, not only as a systems basis, but for each individual patient.
From a community approach, would it help to ease the burden on the doctors to create some patient education videos for these patients who ever have a hypoglycemic event that might be an adjunct to your work? Just so maybe you prescribe them to watch an evidence-based video that you create with your students at UC Davis, and then you do a motivational interview with them after and have them watch it, or something like that to ease the burden on. I mean, everybody in this room wants to do a better job with their diabetic patients, but it's a really complex educational process with the patients.
It is, and there are lots of materials out there. We refer to some of them. There's a full section on patient education, staff education, et cetera, in that workbook I talked about. Again, mostly focused on the inpatient setting, but I think a lot of the principles are the same. Those kinds of videos can be very helpful, I think, but in many cases, you have to be careful because we're asking our patients to review a lot of stuff, and we want to look at things that have good evidence that they're going to work. And I just, my note of caution about it is really, you have to, again, define your best practice and your protocol for your practice, and then I would use the videos to reinforce that, just like you'd use the order set to reinforce that, and other things to reinforce that. So that you're always speaking with a common voice about how you do things in your clinics for those patients.
So normally, I bring a sheet that shows that in Sacramento, we have a higher incidence of heart attacks and strokes. I went over those materials with you, and everybody who comes on a regular basis has seen that material. And we know that diabetics have a much higher incidence of heart attack and stroke, and I'm guessing those patients who have hypoglycemic events, and I'm really out of my depth here because I'm not a clinical person, have a bigger problem with that.
Well, I think they do, but realize the glycemic control part of diabetes isn't really the most, that helps with microvascular complications more than macrovascular complications of major stroke or heart attack. But I do think that the hypoglycemic events can lead to bad events. It does all the things that can cause plaque rupture. It increases the physiological response, causes things that would be associated with higher risk for those sorts of things. The hypoglycemia part is really that correlation isn't that well studied as far as I know, but I think there is probably a correlation.
Bad form in many ways.
Yeah.
So I see, so we want to thank you so much for this incredible lecture, and let's give him a round of applause. Brand new data in your packets. It was just published on the Office of Patient Advocate website showing what our local rates are for blood sugar control. We have a range here of between 39% and 69%, depending on medical group, for blood sugar control for people with diabetes, for hemoglobin A1C 8. And that is a pretty relaxed standard to try to deal with the potential for hypoglycemia. So I think it's important to recognize that we've made some good progress here. And also on the flip side of that page, you have a really big improvement on the controlling blood pressure for people with diabetes. So that gets to the issue of those excess heart attacks and strokes. And you all have it in your packets, and it doesn't look like Greg has a packet. So the other thing that I wanted to mention to you is, unfortunately in our packets this time, somehow we got 2 copies of the evaluation. The one that should have been thrown out, the green one, and the blue one that had the corrected errors. So this blue sheet gives you your opportunity to do your continuing medical education or nursing education. And if you would please be sure to fill that out before you leave and give that to Carla or set it on the table out there. We are a little bit ahead of schedule, and this is the time for the round-the-room discussion and any announcements that people want to make. One announcement that I want to make is that we will not be meeting in this room next month. We will be meeting at UC Berkeley School of Public Health on November 5, where we're bringing all the university best practices across the state together for our day-long event. So we'd love to have you with us, particularly the clinical leaders in the room is who that summit is designed for. So with that, do we have any announcements around the room or discussion about taking off of what Greg just taught us, Dr. Maynard, about a potential diabetes project in the area? Joan Werblin.
I just have an announcement. The California Health Collaborative on November 12th. I have flyers if anybody wants one. We are doing a forum, and I'll read you right from it. It's for honoring the refugee and immigrant communities of Afghanistan, Iraq, and Syria. This is a cultural competency type forum. We're opening it to professionals, no cost, it's here, breakfast is provided, and lunch. The content will be, where are these immigrants and refugees coming from? What are their status here now? What's available to them? What are their health, cultural, and religious beliefs? What is driving their behavior? And our behavior is that we don't understand the culture. And so it's an exchange of information. We have several imams coming to talk about religion. We have professionals coming to talk about the culture. So I would like to invite anyone who wants to attend. You can register online. I have the flyers. And your employees, if you're in a service that deals with these people in any way at all. For instance, we're marketing to firemen, to paramedics, to people in the various churches and schools who are dealing with this immigrant population. So please consider it and spread the word. Thank you.
So I also want to remind you that if you haven't already picked up your hypertension algorithm pocket cards, please see me after this meeting. Tell me how many you need for your systems. And I'm just going to ask, if we don't have a round-the-room discussion, I'll just thank our sponsors, Novo Nordisk, Boehringer Ingelheim, Genentech, and Johnson & Johnson, and say without this being a public-private partnership, this work would not exist. I also want to thank the Health Services Advisory Group for providing the important aspect of this work, the continuing medical education, and urge you to fill out your forms so that we can continue you getting your free continuing medical education credits. So do any of you all have any discussion items for heart attack, stroke, and diabetic complication prevention, better management?
I only had one thought, as Dr. Maynard was talking about the outpatient side. You know, we have a predictive tool that looks at complex patients, and it would seem that I can figure out by age which patients have multiple comorbidities, which ones are diabetics, which ones have dementia or cognitive impairment, and therefore are at very high risk of hypoglycemic events, and give those lists to my primary care physicians to say, you need to have this discussion because your target A1C should be somewhat higher than driving it down to 7 or less than 7. So I think and so this gets right to the outpatient side. How do you identify, transitions of care are one thing, overall management, ongoing management is another. It's a different type of analysis. But I think that's extremely doable.
Yeah, they even would send out, make sure they did the exact same thing, but made sure that they especially targeted those who had a documented lower A1C.
Right.
As
So
an urgent issue.
right, to say if I have a hemoglobin A1C where it's 7,
Right.
those are the people at highest risk, not the ones that are at 9, because that's where you want to be, right? I mean,
They have 7, but they also have dementia,
insulin plus other drugs, liver disease, kidney disease. So yeah, very interesting.
Do you want to comment at
Another
all
project.
about for patients who are hospitalized multiple times a year with hypoglycemic events, any ideas about how to better manage them on the outpatient side with pumps, et cetera?
It's what we've been talking about. It's basically coming up with a rational target. For some of them, for some patients with recurring hypoglycemia, it's because, just like any other health thing, it's because they're not following, they're not taking care of themselves. You run into that more with the willful adolescent type 1 diabetes patient who will, not take insulin and then they'll take it 90, things like that. The ones that are more common, that have recurrent hypoglycemia, are the patients like these older patients who are in regimens that should be changed that aren't. And so I think it all comes down to recognizing that and coming up with A1C targets that make sense and really working with them with experts to walk through the circumstances of their hypoglycemia. It is unbelievable how many ways people can misinterpret what we tell them. You may have heard the joke about the person who came in with their hyperglycemia saying, I don't know why I keep getting hyperglycemic. I've been injecting this grapefruit with insulin, regularly, like they were taught with the grapefruit. Anyway, that might be an exaggeration. But it is amazing how many different ways things can be screwed up. And it can be very simple. It can be in the inpatient setting, we're supposed to have carb-limited diets, but we change food service, and all of a sudden macaroni and cheese is being delivered on a plate this size as one carbohydrate, packet. So, and there's patients who drink, the tub-sized Coke,
With sugar in it?
and then they go to Diet Coke and then they get hypoglycemic. Well, they just cut their calories by about 2,500 calories. So it's getting that kind of history is, you just have to know the right things to look for and keep asking, because there's almost always a rational explanation.
Yeah, my takeaway, thanks to your talk, is really context, A1C, and motivational interviewing.
Yeah.
That's my takeaway.
Well, so one of the things that the Health Services Advisory Group has free support to the community for is diabetes self-management education. And they are supposed to train 450 patients every quarter. And this is being paid by the Centers for Medicaid and Medicare Services. So, Mary, could you elaborate a little bit about the opportunity here to support UC Davis, Greg Maynard in this work? We have all the health systems here. This is free support to you to unburden your physicians.
Right. So we're charged by CMS to conduct diabetic self-education management classes that are evidence-based, such as the Stanford model or the DEEP model. And we are training trainers, okay, so that trainers can then conduct their own workshops. Each of these classes consists of like 8 series of half 2-hour class that the patient has to attend, at least 6 out of the 8, okay. And so our targets are Medicare fee-for-service beneficiaries and dual eligibles. However, and also Medicare Advantage patients. However, any diabetic patients are welcome to attend the classes. So we're looking for partners who can partner with us to conduct these classes. If you're conducting classes already, we'd love to partner with you and give you some support or training materials and things like that. So I think, you know, anyone who has any ideas about partnering can contact me or Chad.
So we know that Mercy Medical Group for sure is going to start enrolling patients in these free diabetes self-management classes. It strikes me that since you're allowed to take your classes to the facilities, you could probably help Leonard Fry with his home health and nursing home patients. I'm not quite sure all the patients you
They're all at home.
serve. They're all at home.
They're not home.
So how would you do it if you can't? That'd be complicated.
Right, that would be complicated because they're probably homebound, most of them. That would not be amenable to this kind of classes.
Can you teach them by the on-demand videos? That's what Dr. Ertl was just asking.
Oh, not yet. CMS has not approved that yet, the online educational classes. But CMS has approved those 2 models. And
I think the problem with the online model is there's no back and forth, and you need to verify that they're actually getting what you're saying.
Yeah.
There's no teach back moment.
But you-
Unless you can, I mean, there are ways to try to automate that and get some sense that they get it, but it's more difficult than a face-to-face center.
But it could be
Don't you have visiting nurses? Don't you have people that go into the homes? You could watch the video together and get that back and forth.
Yes, that's true.
Or you could
Yeah.
ask them to watch it first and then intervene and do that.
Yeah.
Because I think that's it. You know, you can do that at base.
That's a good idea. We have these care managers that,
Joan
And we
has-
have Joan Werblin, who has a lot of work in this field over the, not at all,
No, I would just like to take another look at another side of this. The 37 years that I taught diabetes at UCD, the last 2 years, what the internal medicine department had me doing was a 2-hour class. Supposedly it started out at 15 minutes, ended up by request of the students to be 2 hours with the first year residents. And a lot of it was talking to the patient, managing the diabetes. And one thing that we're not, really talking about is you can watch a million videos, it's one-dimensional. You can do classes, and in 37 years I've done a lot of community classes, as Dr. Arevalo can attest to. But again, if they don't get the follow-up, it really falls flat. It'll go well for a few weeks. And then it's, oh, do I have to do this again? And I have talked to you before about my years spent with the migrant laborers down in Southern California in the fields. After a while, if there's no backup. And so one of the things I think that doesn't seem to get done is education for our future physicians on interviewing the patient, and then the follow-up, not just while you're, an intern or what in the hospital, but when you're actually out in the clinics, that what comes up in the computer. And I tried at the Med Center to get it incorporated, and I got a lot of pushback. But when I was in London, courtesy of one of the pharmaceuticals, they had done a simple thing for the doctors in the outpatient. It was a stand-up card like we have. On one side was a beautiful piece of art. That's what the patient saw. On the other side were very key questions to remind the doctor, your blood sugar went low. How come? Was there food? Oftentimes there's no food in the refrigerator. The food stamps haven't come out yet. They've lost their support system. They've got to feed the kids first. And I had one lady who didn't take her insulin, and I said, the doctor sent you to me. You know, it's always punitive they were sent to me because you stopped taking your insulin. Why? Well, we ran out of food, and you said, if you know, you have to eat when you take insulin or you're going to have a low blood sugar. So I stopped my insulin because we didn't have any food for 2 days. Physicians, I know everybody's busy, but that's becoming kind of cliche. We need to find out more things, more in-depth, talk to our patients when they come back. That's when you start to see progress because it gets reinforced. They know somebody cares. It's like patients would say to me, I stopped doing my finger stick because I have a book full of numbers and nobody ever asked to look at it. So why am I doing it? I mean, it sounds simple, and I know you've all heard it before, but I think we need to take some action on some of those things. It's not just the hemoglobin A1C, the numbers. It's what makes those numbers, and that's the patient.
So, two things before we get to Lisa, who is a professor of pharmacy, and I'm sure the pharmacists can play a really great role here. But with all your years of diabetic education, Joan, this is for you. So here's CMS telling their contractor for California, you need to do these diabetes education classes. They have to be 2 hours long. You have to give 8 classes. The patient only qualifies for having completed the class if they've done 6 out of the 8 classes. What did you find needs to be the dose and the interval for the classes?
Well, we did them weekly. That was one thing, so that there was consistency. Because they'll drift away. You say once a month, they won't be back. Or they'll make a couple of them. We also found it has to be taught in the patient's language. And I don't just mean whether if they're Hispanic or Vietnamese or, you know, the ethnic languages, but I'm talking about in the patient's language and get it out of the vernacular. So many of these programs take a shotgun approach. It's been written down very nicely by very educated people following an outline, but it really isn't what the people want to know. They want to hear it in terms that they understand. I mean, we had to get down simply saying, if you eat a meal and it goes in your mouth, where does it go? What happens to the food? What is blood glucose? And, you know, use and don't use scientific terms. We had to break it down into everyday language that people understand. The other thing we found that did was it broke down the barriers because we weren't speaking as medical people. We weren't speaking as the highly educated people. We were speaking as people who were concerned, and we want you to understand how to take care of yourself. Not something that we're lecturing down to you in our language, but we're sitting here at your level talking. I mean, it was very basic things, but we had 200 patients that, you know, did well.
Great. Well, hopefully you and Mary can consult a little bit on that offline. Professor Ashton?
Yeah, I was just wondering if this is an opportunity to work with us, community health workers and promotorians in conjunction with some of the online videos and the resources that are there, you know, so that you have a partner to sit with you and watch a movie or a video, and someone who can call you at the end of the week to say, did you do the, you know, XYZ, you know, did you